Okay, now I'll introduce Dr. Noonan. Dr. Daniel Noonan completed medical school at the University of Missouri Columbia and internal medicine residency at the University of Minnesota in Minneapolis. He went on to perform his cardiovascular medicine fellowship at Albuquerque and cardiac electrophysiology in Salt Lake. If you've driven around the Treasure Valley lately, you have seen his billboards for high desert heart and vascular, which he and 3 other physicians opened after leaving St. Luke's last year. In his clinic, he focuses on heart rhythm disorders. In the OR, he does minor surgical procedures. And for sports and exercise cardiology, he focuses on wellness and longevity while evaluating athletes at all levels.
That's right.
Dr. Noonan.
Well, thank you. Thank you. We'll first start with a mic check. I've been up here. I'm double gunslinging up here. So if you can't hear me, let me know quick. More? We tried. It's not for a lacking of effort.
That's on standby. You're good?
Okay.
Good?
Better? Okay. If it gets too loud, just give me a signal because it is echoing up here. Happy Friday. Thank you guys for having me. Thanks for being up here. I'm excited to do this. It's I love doing this talk. We think that atrial fibrillation is one of the coolest things to talk about because there's so much to talk about and it changes. And to be real honest with you, atrial fibrillation is smarter than we are. So use this as an interactive time. Use me. I'm an open book. Ask as many questions as you can think of. I'll try and come up with some fairly nuanced answers and give you a good overview. So I'm not going to deep dive too much into hardcore science. The last thing you want on a Friday morning is some dorky electrophysiologist talking to you about very deep science. So I won't do that. But if you need that, you can always pull me aside at some point down the line. The other thing to tell you is today is National Employees Day. So if you really want to impress your employees, feel free to text them or tell your office manager. I know that because I got that text last night. Sorry about the billboards as well. I've had a couple guys walk up to me. My wife and I have been having dinner or breakfast or something, and some guy will pull me out and say, "I see you every morning at my house." I'm like, she looks at me funny, and it's on the billboard. Oh, that's right. Okay, well, I apologize. But thanks for considering us when you guys are thinking about your cardiovascular care. I have no relevant disclosures today. So we have about an hour. It's about a minute a slide. I will probably get behind or speed up. So Steve has a clock here to keep me honest, and I'll do what I can. But just giving you an idea of what we want to go through today. I always think about in these talks, why do I care about this stuff? Is this something that's ever going to be pertinent to me? And there's not a person in this room that atrial fibrillation won't be pertinent to you, either to your patients or to someone in your family. And I'll show you why that is. We'll do a little bit of dorky stuff with epidemiology and pathophysiology and make it as interesting as we can, but please feel free, again, keep it open and ask questions. There's a new classification and stages of atrial fibrillation. It's not really anything new or remarkable or robust that you haven't seen in other areas of medicine, specifically something like heart failure. We can go through that a little bit. It frames, I think, the disease as a progressive disease, which I think is helpful. 3 pillars of management we want to talk about, which are obviously risk factors and modifications, how you treat it, and stroke prevention. And that's going to be a big topic of what we talk about this morning is try and think of it in this trimodal sort of area. And I do this in clinic with patients all the time. I say, okay, look, we're going to talk about these 3 things. Think of it as a trident. Let's talk about how did you get here and how do we keep it from getting worse? Let's talk about number 2. The worst thing you can have is a stroke, right? Here I am, a cardiologist, and I say, give me a heart attack almost any day of the week. What I don't want is a stroke. And I say it for a little bit of theatrical effect, of course, but I mean it sincerely. As you guys all have, I've seen so many debilitating strokes and the things that it actually does to your mental sort of state afterwards when that happens. Oftentimes the pleiotropic effects are more cumbersome than the actual event. And so I think that's a really big deal. That's really where your mortality and morbidity lie, and where I think we can improve very easily. And then next, and sort of the third arm, is treatment of atrial fibrillation. So the actual rhythm, how fast is it going? How do you feel in it? And you do that last because generally those folks are bringing that on themselves. And that's just the sad reality of atrial fibrillation, is that oftentimes we're doing this to ourselves. And the answer is, you can take away most of your AFib. You can take away most of your cardiovascular disease. It's simple, it's just not easy. And no one ever wants to hear it. This is the one where they say, okay, well, you got to lose a lot of weight. You got to quit smoking. You got to exercise more. And so if you think about those three things, you can help frame that conversation in clinic. So why do you care about it? We talked about, so this is the most common arrhythmia on earth. Both incidence and prevalence are increasing substantially. We'll go over that. AFib costs a ton. I'll give you a slide about this too, but this is extremely expensive to the medical community. When you have AFib, you're sicker. You're just a sicker person. You're a sicker person, you stay in the hospital longer. Your simple, spinal injection, your simple hip replacement, it prolongs your hospital stay by 4 or 5 days. And you can see how that costs add up. And so just giving you sort of an idea of how that looks, we're talking about 5 million people in the United States with atrial fibrillation. And I'll give you a sort of frame that and give you how that looks to give a real idea. That number goes up significantly. I think that is actually underestimating that by quite a bit. And so we talk about 33.5 million people with atrial fibrillation. On a daily basis, if I see 25 people in clinic, I can see 20 people with brand new AFib, not follow-up AFib, brand new AFib. That's every day for the last 13 years that I've been doing this. 2 days a week, 20 new patients a day with brand spanking new AFib. Think about that. So we know this is a really common problem. At least 0.5% of the world's population has atrial fibrillation. And believe it or not, you guys, I'm the rarest person on planet Earth. 0.17%. I'm the smallest minority there is. And we're actually a dying breed. So you can see this, the red hair is going away. It's a thing. So very much more common than even that poor. Could I have been anything else? Could I, an engineer maybe, a neuroscientist, or an astrophysicist or something? My career choice, I'm always 5 minutes late, and my handwriting sucks. It's the only C I ever got. So I really had no choice but to go into electrophysiology. So cost-wise, $26 billion. $26 billion on a disease that's almost completely preventable. Swallow those numbers for a second. It's probably in 2 to 8% of people, it's not preventable. $26 billion. Blows my mind. When you have AFib and you get admitted to the hospital, you stay in there longer. They're on Coumadin, they have a bleed, they need Lovenox, their heart rate sucks. They're there for 3 or 4 days. You've all seen it, so we know this is, of course, this is the case. So these are from the guidelines. Basically, AFib is increasing across the board for, is there a pointer on here, Steve? Middle. Across the board for essentially any group you can think of, AFib is going up. I don't think that's a hard sell. So we've known about this for a very long time. So first known sort of description of this, we call this l'arythmie complète. I will sneak a couple of French things in there because I'm a bit of a French Francophile. So I apologize about that, but it's a very interesting disease. And when I said in the beginning that AFib is smarter than we are, I'm sticking to that. So we talked about all these other heart rhythm problems, AV node reentry, atrial tachycardia, WPW, whatever it may be. We know these mechanisms very, very well. I can sit there and wax philosophic and tell you how it started. AFib, we don't really know. We have no clue how it starts. We know that it used all of the mechanisms available to us in electrophysiology. So we think about automaticity. I won't get too dorky into this, but there are these three mechanisms. You think about automaticity, and that's how, anyone know how many times a day your heart beats? How many? 100,000 times. 100,000 heartbeats every single day. Sinus node just does this. Little chemicals going in 100,000 times every single day. So when people come and we talk about AFib, and they say, yeah, you have 1% AFib. You have 100,000 heartbeats every day for the last 24 hours a day, 7 days a week for the last 52 years of your life. You have less than 1% of your heartbeats that are going a little funny. I just want you to put that in perspective. 100,000 heartbeats a day. Automaticity is your sinus node. This is how it happens every single day. So we also know with atrial fibrillation in the upper left chamber in your heart that you can have areas that exhibit automaticity, specifically the pulmonary veins. So when you think about have the heart, two pulmonary veins on the left side, two pulmonary veins on the right side. Where the pulmonary veins enter the backside of the left atrium, it's not like there's just a sign there that says pulmonary vein, left atrium, and you stop. This is a really mismatched, mangled sort of histologic part. In that mismatched, mangled histologic part are automatic cells. Those cells are responsible for about 80% of people going into atrial fibrillation. So that's the automaticity portion. And I'll show you some cool videos of that, how we know that. And that's what we do when we talk about an AFib ablation, is we mostly target that mechanism. Triggered activity. So you think about triggered activity. And so just going back so you don't get too lost, but these are the mechanisms by which you go into atrial fibrillation. So that's just one. We treat that one very well. The other ones, we don't treat all that well. So triggered activity is, you've heard about torsade de pointes. So these are your delayed after depolarizations, you know, your classic, you're doing a cardioversion or something in the ER and you say, you got to sync the machine, right? You don't want to have R on T phenomena. This is a version of R on T phenomena. So these early or late after depolarizations, think of them as PACs, sometimes PVCs, but oftentimes PACs. They start in a vulnerable period of your cardiac cycle. So you can remember QRS, T wave, QRS, T wave. There's also, if you go down beneath that, you talk about intracellular. You have a big spike, and then it goes down. And in there, all the different chemicals, calcium, potassium. I'm not going to go through it because it'll put everybody to sleep. But when those particular influxes and effluxes happen, let's call it in that vulnerable period between the end of the QRS and the T wave, people go into atrial fibrillation. We see this a whole bunch at night. Tons of people. Think, next time you have someone with fib, ask them when they went into AFib. Half of them will do it in the middle of the night. Why is that? Heart rate's going like this all day. 80 beats a minute. At night, where you have higher parasympathetic tone, you're sleeping, your heart rate slows down. So now you're at 40. So what does that do? Much longer vulnerable period. Many more vulnerable, much wider vulnerable period for a PAC to come in there. That PAC sends you into AFib. So second mechanism of atrial fibrillation induction is triggered activity. And third is reentrant. So this comes in handy for, I'll show you a picture of this as well, but electricity is, it flows. Think of it as a wake. right? So you have a speedboat. As your speedboat's going, you have a wake behind you. Or you can think of it, it's a little grosser, but think about it as a toilet flush. Flush the toilet, it's got to go down, it's got to refill at the tank. That takes some time. That is the time period that it takes for a cell to repolarize. Ions to go in, ions to go out, cell to repolarize. What can happen is, thinking about this wake analogy, as electricity is coming from the top part of the heart, electricity always travels like this. As it's going from the top to the bottom, there's a wake behind it. If you get another PAC to come in there, and that happens pretty commonly, it hits partially refractory tissue. So this is sort of when you flush the toilet, didn't quite wait until the whole thing needed to go down, and you flush it, and you sort of get this wimpy flush, and you're like, God dang it, that's AFib. I did that intentionally. And so we see this in a whole bunch of, this is the most common way to go into dysrhythmia. So this is your classic SVT. This is AV node reentry tachycardia. Heart rate goes from 0 to 180. They have to go into the ER. It's all because of different refractory periods. You can take different paths. So this obstacle that we're talking about, it can be a barrier, it can be an obstacle, or it can be an electrical obstacle. Electricity goes one way around a barrier, PAC comes the other way around a barrier, and suddenly your heart rate doubled. It's going around that obstacle, and it set up that loop. So we see that a whole bunch, more with SVT, but we also see that with this. So just giving an idea why we still don't know a whole bunch about how AFib starts. And sadly, we have no idea how atrial fibrillation stops. No clue. I have no idea how atrial fibrillation. The same thing with VF. You guys have seen this in the ER. Someone will go into VF and then it just stops. You didn't shock them. How's that stop? Well, no clue. Same thing with AFib. Why does this stop in the middle of the night? No idea. We can make things up, but we don't know. So AFib is smarter than this. So it goes and speaks to the progressive nature of AFib, right? So 2000 BC, we've known about this for a very long time. Fascinating to me that people can do this. The dude who invented Winky Bach, German guy, I believe, or maybe he was Austrian, Winky Bach, he didn't do it by an EKG. EKG wasn't invented. He did it by looking at someone's pulse in their neck. Do you look at the pulses in the neck? I don't look at the pulses in the neck. Kidding a little, but it's crazy to me, right? It's crazy. So that's the second most important thing on this slide. The most important thing is, where did that dude get that hat? That thing is sick. I love this thing. Okay, so just going through this a little, this is a little bit of the boring part. William Einthoven, any idea who that is? You've all heard of him. You all use him every single day. He's Einthoven's triangle. When you get an EKG and you talk about lead 1, lead 2, and lead 3 in your precordial, he's the dude that invented that. It bought him a Nobel Prize in, I think, 1924 or something. So he's an important guy, but he was also thinking about atrial fibrillation then, okay? Sir Thomas Lewis, an English guy, who basically was at the same time as Einthoven. 1927, he was knighted, but they talk about these circus movements, and I'll show you what that looks like from an electroanatomic map inside the operating room today. And it really is that, just completely chaotic movement inside the left atrium. This last one is interesting to me. It's more just interesting. As I show the slide, I want to go through it, but I told you we don't really know how AFib stops unless I give someone Idaho power and shock them, right? That's the best procedure there is. I get to walk into a room, they come in for a cardioversion, and I say, you know why I like my job? You're paying me to electrocute you. This is great. Like, who gets a better gig than this? So how does it keep going? How does it perpetuate itself? I have no idea. It should just stop itself, but it doesn't. It just keeps going. It's still fascinating to us. So we don't really know. We wish we knew more about AFib. It really is smarter than us. We say that to sort of mock our own deficiencies, but let patients know at the same time, hey, this is a progressive thing. We're going to do everything we can, but part of the job is on you. A big part of the job is on you. There's really not a one size fits all. I'll get into the risk factors, but this is a really systemic process. Many of the things in the heart are a really systemic process. The manifestation is cardiac. We all say, well, I don't know, send it to the cardiologist. And that's cool. Keep doing that. Please keep doing that. I appreciate that. But the reality is the heart usually is secondary to this stuff. The things we're doing to ourselves is what's causing this situation to put us in atrial fibrillation. And that's these risk factors. So we talk about sleep apnea. I'll go into why that leads the league in causing AFib. We talk about hypertension, of course, CHF makes a lot of sense, coronary disease, obesity, type 2 live-beatus. I'm not going to call it diabetes because that gives you a terrible prognosis. So we're going to go with live-beatus. Just stick with me there. Drinking too much booze, smoking, genetic factors. Everybody wants to blame it on the genes. Guess what? It's probably not the genes. That might be playing a role, but it's usually not the genes. Inflammation, and in recent surgeries, that really lights it up. So think about that as, you know, as many of your patients go into the operating room or they get sick, try and keep folks on their antiarrhythmics. They see a drug, they're like, flecainide, sotalol, not doing that, that's stopping. I don't even know what that drug does. Don't do that. Because then they just have to come see me. We have to cardiovert them, and it's a many weeks long process. So just keep the drug going. And so I tell folks all the time, and that's sort of, it's unfortunate to tell them that we don't have a cure for AFib. Like, there's no cure. So this is a chronic disease. This is a chronic progressive disease. And we're going to do our best. We're going to beat it up. We're going to get you go from this to this, but there is no cure. The expectation can't be zero AFib, and it can't be to cure AFib. It's sort of like dentures or a knee replacement. They're fine. You can eat an apple, you can walk up and down, but it's never like what you had normally. You're always sort of fighting with having your knee replacement, a little bit of pain, or doing something with your dentures. It's not quite perfect, but it's still pretty darn good. Any questions about that so far? Sweet.
What is the pathophysiology? What is the pathophysiology? Why they convert by slowing them down? And then my second question is not even related, is that I often wonder how the AFib might be triggered by electrolyte disturbance. So they're put on hydrochlorothiazide for their hypertension, and they come in, they're potassium in the toilet, the magnesium in the toilet, replace all that, and then they go, then they'll convert. So just wondering how much of an impact you think that has.
Yeah, absolutely. So question number one was, after we slow someone down, how does atrial fibrillation terminate? And generally slowing them down pharmacologically. And then question number two was, how does electrolyte derangements, how does that impact the development, initiation, perpetuation of atrial fib? So number one, when you slow them down, just like I described, that you have increased vagal tone at night, same thing can happen as you slow them down, where you take advantage of that obstacle. So many people, that won't happen to everybody, right? It only happens to some. So there has to be a particular situation where an obstacle is created. The AFib will hit an obstacle and it will find tissue that is completely refractory. So it's like flushing the toilet, and then you flush it immediately. Nothing happens. You're just gonna keep popping that thing. So it hit nothing happens. So AFib terminates. That's one mechanism. Another mechanism is spontaneity. So we talk about the sinus node going like this 60 to 100 times a day or a minute. That cell can also just stop. It just gets tired. Happens very, very commonly. We actually see that in the operating room too, where you're mapping a cell, you're mapping an area. Let's not call it a cell, but you're mapping an area. Just stops on its own for no reason, haven't done anything, nothing has changed. So we see that a whole bunch. And then third, they're natural obstacles. So, and we can see this as soon as we put catheters in the heart, I can map their heart and I can say, ooh, this person's a drinker, this person's not a drinker. I can see how healthy their tissue voltage is. Those create fibrous areas, scars inside the heart. They hit those scars as a spontaneous discharge hits the scar, it stops. If you don't have enough fib, you're not going to have another wavelet coming by somewhere. So maybe you just had one of those foci. And then number two, electrolyte derangements. I honestly don't see that impacting it a whole bunch. It certainly does, don't get me wrong. But we don't see that a whole bunch. And the reason is, while we're looking at these electrolytes, you talk about potassium, calcium, sodium, magnesium, those are the most regulated ions in our body. And so even what we're seeing often doesn't reflect what's happening on an intracellular level. So I don't see that it impacts. Does it impact? For sure. And so specifically, you know, we talk about calcium, potassium, and sodium. You don't see a whole bunch of problems with those that are causing AFib. You do see it in magnesium. So a hypomagnesiemic state, of which we almost all are, that's a huge problem. And in fact, I have most of my patients on some degree of magnesium replacement. As we're monocropping a whole bunch, there's just depleted elements in our vegetables, in much of our food. And a lot of the first one it loses is magnesium. So we're woefully inadequate in magnesium. No, because magnesium is intracellular. So what you see is an extracellular manifestation of that. It's generally going to be in a normal range, but we can't really measure it all that well. But the flip side of that is you can't really overdose on magnesium. I mean, it's different for pregnancy, things like this, and different if you're taking gallons of magnesium. But whether you're taking 400 milligrams twice a day of magnesium, or whether you're taking 2,000 milligrams a day of magnesium, the limiter, anyone know? It's diarrhea, and it sucks. It really stinks. So they will stop before they can overdose on magnesium. So go ahead, you just do it. And in fact, I give them 3 forms of magnesium to take because people have different tolerances to different magnesium. So specifically things like magnesium threonate can cross the blood-brain barrier, helps with sleep a whole bunch, versus the other ones, magnesium oxide, glycinate. Each of these are absorbed to different frequencies in the bowels. So they'll have to adjust with those. But think about magnesium, not only for AFib patients, but for all of us. We should all be taking some degree of magnesium supplementation. Any other questions? Okay, so just thinking about how complex this is, a little bit of a dorky slide, but I like it. So we talk about micro reentrant circuits. These are these little wavelets. We've even invented ways that we can go in and find these little wavelets. They're tiny little rotors where obstacle in the middle, PAC starts, spins around, and just, it's like one of those Chinese things that spin off the fireworks, goes around this little wavelet, and bam, you get tons of electrical forces or electrical discharges that are going to put you into fib. These are called rotors. We see these a whole bunch. Moving on to pulmonary vein foci. And so this is sort of the depiction. This is the back side of the heart. So you're looking back. This is the left atrium here. These are the 4 pulmonary veins. So these are left-sided pulmonary veins, right-sided pulmonary veins. This is your SVC. This is your IVC. They truly are this close. I mean, if we were not cognizant of what we were doing, we could very easily burn a hole from your right superior vein into your SVC. It's very possible. Right behind here is your esophagus. Generally between your esophagus and your heart is millimeters of paraesophageal and pericardial fat. Just to give you an idea of how close all these things are. Okay, so this gives you an idea, or will show you an idea of several things. Why is sleep apnea so important in the development of atrial fibrillation? Because I'm here to tell you it leads the league in causing AFib. It is 1 through 9. It is the top 9 home run hitters in AFib is sleep apnea. It's not just something we all come in and say, hey, does your husband snore at night? And the wife's like, oh yeah, for sure he snores. Doesn't want to go get a CPAP because no one wants to wear a CPAP, but he's also in fib. It caused it for sure. It's a big deal. It's not just us like saying this because we want to, hear ourselves talk or something. Big deal. And this is why. Think of these as histologic tissues. So you can see the rings around each of these veins. This is cardiac muscle. You can look at cardiac muscle. You all remember this. If you look at a muscle under a microscope, it looks like this. You get a contraction, goes like this. It relaxes, goes like this. These muscles do the exact same thing, and they're all going in very different directions. If you take a biopsy of another muscle in the body, oftentimes it's nice, it's linear, it looks good, it looks pretty. Blow it up, it could be a piece of art. The left atrium is not that. It's mangled. There are natural obstacles because of the sleeve of muscle that surrounds the pulmonary veins. You can see these here and here. You can see the outside. These are true myocardial fibers outside of the heart. On the inside, this is the posterior wall of your heart. It's like driving in Mexico City. It's crazy. You might as well have hypertrophic cardiomyopathy of the posterior wall of your left atrium. That's a very dominant arrhythmogenic part of your heart. And you can see it here. It looks like a mess. And this is what it looks like histologically. And so AFib, going back to AFib and pulmonary veins. As you have these signals here from each of these fibers that actually can extend into the pulmonary vein sleeve, they get pretty mad when they're hypoxic. What happens when you have sleep apnea? You get hypoxic. The cells that feel that the most are these cells here. When they get hypoxic, they get scarred. When they get scarred, they get angry. When they get angry, they fire off discharges. Those discharges are these depolarizations that I'm talking about, or microwave reentry circuits. So we'll walk you through the scenario. You have sleep apnea, you're hypoxic here. You get a bunch of angry cells, firing discharges, you go into AFib. So this is what we do on a first AFib ablation. So we basically make an electrical dam around these veins, so that when those discharges come into the left atrium, it hits that line of block and it can't put you into fib. And then I'll show you why that's not a perfect procedure. It gets us a long way, but it's not perfect. Dominant spiral wave, we're talking about sort of rotors on a macroscopic level, which will lead us to, at times, like I said, we will go ahead and isolate these veins so that those signals can't come in. On your next ablation, we will isolate this posterior wall, which is not the easiest thing to do. It's getting easier every day, but isolate this to avoid the dominant spiral wave because it's such an arrhythmogenic part of your heart. And then next is vagal ganglia. So fortunately, we take advantage of our collateral damage. When we're heating tissue, the heat isn't just like, I want heat right here. It can pass to other tissue. And part of that tissue is vagal ganglia. You have numerous autonomic foci on the outside of the heart. That's why your heart slows down at night. That's why your heart slows down when you're eating. This is your rest respond or your rest relax versus your fight or flight. You have multiple areas in the heart that will slow the heart down from a vagal standpoint. We ablate those. We don't go hunting for them most of the time, but they live in known locations. And so as we burn them, it's great. See, the heart just goes. You're pacing the heart at 60 beats a minute, and then that gets the anesthesiologist's attention. You never want to look over and be like, why are you standing up? You should be sitting down reading your magazine or something. But we do this, they stand up and you can hear their chair. You know what's happening before it. It's great. You don't warn them about it. Just let them go. Just want to check and see if you're awake, Bob. Sorry. And then next is the ligament of Marshall. This is a profound vein of our existence. It's actually a vein. So it is a remnant of a vein that has now become ligamentized, but it lives between the left atrial appendage, which is right here, just in front of your left superior pulmonary vein. And it can also light up a bunch of AFib. A lot of those cells live in there, and we can't get to it very well. It's a big pain. Okay. Do it on time. We're gonna have to speed up a little. I have waxed philosophic too much. So this is a staging for atrial fibrillation. We'll go through it reasonably quick. Very similar to heart failure. So you know your class 1, 2, 3 heart failure. You're at risk, have a little bit, have a little more, can't do anything, need a transplant. Sort of that this is that to a sort of dumbed down extent. But stage 1, you have the presence of risk factors. Guess what? All of us have the presence of risk factors. Find someone who doesn't. Well-trained athletes? No. 2 to 4% of all people that go into atrial fibrillation are well-trained athletes. So find me someone who doesn't have a risk factor for AFib. So we're all basically here. Number 2, structural remodeling. And are you predisposed to AFib? So are you obese? Are you a smoker? Do you have sleep apnea? Has the heart already dilated a little bit? When I talked about the muscle, if you're looking at heart muscle under a microscope, histologically, it looks like this. If it looks like this, then the heart dilates. So if left atrium is supposed to be like this, but you come in and it's like this, predisposition to AFib. And this is your mildly dilated left atrium that you'll see on echocardiograms all the time. That's not to say if you have a mildly dilated left atrium, you have to go see the cardiologist. I'm not saying that, but just know that is a predisposition. Stage 3, and so this is probably what you're more familiar with. You talk about paroxysmal atrial fibrillation. Atrial fibrillation, it basically shows up, goes away in less than 7 days, and is not coming back. Don't see that a whole bunch, be real honest with you. We definitely see it. But almost all paroxysmal atrial fibrillation is really trying hard to be persistent atrial fibrillation. Persistent atrial fibrillation lasts longer than 7 days, needs a cardioversion, needs drugs, needs some intervention to get you out of AFib. Long-standing persistent atrial fibrillation for at least over a year. Scheduled AF ablation. I disagree with this. we're not going to talk about that too much. And then stage 4 is permanent AF. So you now have permanent or chronic atrial fibrillation, and now we talk about a rate control strategy or a pacemaker. So then we talk about, it's a nice way to look at it, right? It just gives you a good idea of what we're doing. So at the foundation of management for atrial fibrillation, you want to talk about head to toe. These are your risk factors. These are the things we need to be treating. If they have heart failure, get it optimized. By the way, when folks have heart failure, they do very well with ablation. Much better actually than folks without heart failure for some strange reason. Not much better, let me walk that back. They do better than we expected, and they ultimately do very well. Exercise is a big deal. If you could take and bottle exercise into a pill, and everyone now knows this, most potent pill on the planet for the disease that causes the most morbidity and mortality, and it's free. It's a 14 to 17% mortality reduction. There is no pill, there is no surgery, there is no talk, there is nothing we can do that will outlive exercise. Move your body. That's the thing to the patients. And if you can tell them, look, I can talk all day and I can give you all the tools. You have more tools yourself than anything I can give you. Exercise, and it doesn't take a whole bunch. The more you do, probably better, until you get to that 2 to 4% that actually induces AFib. But exercise is the key. Exercise is 14 to 70% mortality reduction. It's mind-blowing from something that we can do ourselves. Oh dear. Hypertension, treat blood pressure. Trying to avoid the live beatus. That's just, we just don't want to be having live beatus. It causes all sorts of problems. Don't smoke. Don't become obese. I mean, this is not a vanity thing. This is not telling anyone, you shouldn't be fat. That's not the thing. Just think of it from a knuckle dragging physics perspective. There's tons more tissue for your heart to pump against. Each of those small arterioles, your heart has to generate enough energy to push through all that stuff. That's a big deal. That's real big. Oftentimes people will double their surface area with just a mild amount of obesity. Your heart has those 100,000 beats. They're working harder. They got to pump harder. I mean, if you think of it like that, it's just, this is not us saying, don't be fat. It's a huge deal. It's a state of inflammation. It is a perpetual state of inflammation. Also a big deal, which is why we see on all these drugs, you talk about these Ozempic things, there's a 20% reduction in cardiovascular events with weight loss. That's mind-blowing. Mind-blowing. It will be a big deal. I know many of you may have questions about that, but it walks it back to show you this is not a vanity thing. This is a health thing. This is an inflammation thing. Avoid booze. Is what it is. We can see there's no, should I say this? I'm going to walk it back, and I know we're on videotape, but there's no safe amount of alcohol. There's just not. It's tough for me to say it out loud. I don't even like myself when I say it out loud, but it's just the truth. And I can see it. I can see it in your heart. I can put catheters in your heart. I can take a pious, lovely Catholic nun who's never had a drink of alcohol her whole life, and I can take the rest of us. Pick. I don't care who. Pick someone. I can put catheters in the heart. I can map it. I can see just from the scarring from alcohol. Everything else, take skinny, tiny, both tiny little people, no sleep apnea. You can see the scarring, and I'll show it to you. And then sleep. Get sleep. Got to sleep. Sleep's a big deal. You know, how many books do we want to read about sleep? This is a whole nother lecture we could talk about, but it's a huge deal. Take care of your sleep apnea and get some sleep. Okay, so we'll side through that in the interest of time. So if you're going to focus on things and you're going to talk about people, be your own best advocate, right? Do everything you can to not come in and see me. I'm a terrible businessman. I'm telling this to people all the time, but don't come in and see me. This is how you don't see me. Decrease your weight. Be super active, not super active. 30 minutes a day, 5 days a week. That's what they say. Double that. That's easy. Go to an hour a day of moving your body. And it is a mixture. It is a mixture of weight resistance and aerobic stuff. There's not a magical pill. I generally think that weight resistance is more effective. We can have offline conversations about that rather than aerobic stuff. But the reality is it takes both. So be active. An hour a day really is not all that much to ask in our lives. Quit smoking, don't drink too much, and control these things. Big, big deals. Okay, any questions about that before we go into treatment and fun videos?
Get the alcoholic.
That was cool.
If the person that has fibrillation due to alcohol quits their alcohol use, does the tissue regenerate somewhat? That's scarring?
That's a great question. So if you've been drinking a lot and you quit drinking, will the tissue regenerate? Not really. A little. Definitely a little bit, but it's not liver and it's not lung. So those are highly regenerative tissues. This is not that. So same thing with sleep apnea. We used to be really archaic and mean. We used to say, look, if you're not going to wear your CPAP, you're not going to AFib ablation. It was terribly rude. I feel bad saying it out loud again. But what we found was the reality is you stop the progression of AFib with these things. It just doesn't get worse. Does it improve? It doesn't improve a whole bunch. Same thing with a clot, right? If you have a clot somewhere, Eliquis or Coumadin, they're not dissolving your clot. Your body's dissolving your clot. It's just keeping it from getting bigger. So same thing here. Stop the progression. Don't let it get worse. But you will get a little bit of improvement. Fair. Okay, so treatment, go through them quick. Talk about treatment for AFib and stroke prevention. Think about those two things. I always see myself doing this in clinic. Let's talk about how we treat your AFib. How do we keep you from having a stroke? Rate control. You can certainly do rate control. It's an okay thing to do. It's not the best thing to do. You're basically just putting off the inevitable. The earlier we can intervene, the better people do. As a perfect segue to your question, thank you very much. The earlier we intervene, the earlier you take action for yourself, the better we can do. So if you're just sitting in clinic and be like, here's your DILT, I mean, it's helping, but we could be better. We should demand better. We should be a little bit better. Now, granted, you're going to do that to the little 92-year-old lady who weighs 83 pounds. Perfect. You should definitely do that. But this 50-year-old person who's like, I don't really feel like talking to a cardiologist, so just get. Now, I would say mostly unequivocally that there's an association with increased Alzheimer's for sure. And that makes sense just from sort of a 500-foot view, right? Like you're not feeding those parts of the brain, man, something's going to happen. You can see that. That moves people's needle, by the way. You start telling them there's a less risk of Alzheimer's, people will get pretty intrigued by that. Rate control. So we can talk about just acute rate control. Obviously, this is either me or Dr. Souther doing that. Fun thing to do. If you get to do it, tell them it's cool to electrocute them. It gets a laugh out of them. That's fine. You can definitely do that. If you are fine, and this is just rate control in the clinic, ask yourself, do they have heart failure? Do they not have heart failure? If they do not have heart failure, you can basically use whatever you'd like. Beta blockers, doesn't really matter which one you use. They're all fine. Why do we have 20 different beta blockers? I don't know. Capitalist society, who knows? Pick your favorite beta blocker, go with it. I mean that sincerely. Verapamil or DILT. DILT is cheaper. Verapamil tends to be more expensive. There's an XL formulation of it that everybody wants. So unless you have to use verapamil, it oftentimes is a BID or TID drug. People don't like that, so stick with DILT. Digoxin, mostly falling out of favor. It works, but don't love it. If they have heart failure, we can go with amiodarone. You should avoid the dihydropyridine or non-dihydropyridine calcium channel blockers, verapamil and DILT. It can actually worsen heart failure because they are a negative inotrope. So they make your heart pump less effectively. Long-term rate control, basically the same thing. So EF is okay. Talk about your DILT or verapamil or a beta blocker. If your EF is low, beta blockers. In this instance, your beta blocker choice does matter. So if you're using a beta blocker in someone with heart failure, you're going to want to stick to something like Toprol XL. the XL formulation, not just the tartrate formulation. And you'll also want to stick to carvedilol. Carvedilol is both an alpha and a beta blocker, alpha 1 and beta blocker. So you get a pronounced hypotensive effect. So if you're having struggles with hypertension treatment, Coreg is more potent than the others. Also be cognizant about that as you start these drugs. Next. Okay. I'm probably gonna skip these. Do you guys really want to talk about antiarrhythmic drugs or see cool photos? I think so too. You pull me aside online and you'll have access to all these. Okay, so ablation. Ablation is what we do most line. It truly is a first line therapy for AFib. I'm not going to ablate someone if they have 1 hour of fib, but if you've had some reasonable amount of fib, is that a week? Is that a couple days? Something, we can make some progress. And in fact, we do better with people with an ablation. At this point, an ablation is an outpatient surgery. It takes an hour. Sometimes people go home the same day, sometimes they stay overnight. When we talk about ablation, we can talk about radiofrequency ablation that uses heat to destroy the tissues. I'll show you photos of that. Cryoablation, which most people do not use, it uses cold to destroy the tissues and still causes the same amount of collateral damage as heat. There's a novel therapy called pulsed field ablation. Patients may ask you about it, PFA for short. It's using electrical pulses that put holes in tissue membranes, so you slowly get cell death, not by heating or cold, but by essentially leaking the cell to death. Pretty quick procedure. At this point, data is it's about the same with RF ablation in experienced hands, but this will be coming up more commonly and more frequently. Patients will ask you about it. And under the bar there is epicardial ablation. I threw that in there for Ben Taylor, who's supposed to be here, but I didn't see him, so we're going to move by it. I say that with love. I think, so there's a video. Do you know how to? Oh dear. Oh dear.
That it?
Negative, Ghost Rider.
Oh, it's not. That on there?
We'll do it on the last one. This one we can do, but does it do the last one?
I know. Do you see it down there? Oh, there it is.
Hey. Okay. So this is what we do in an ablation. It's a nice little cartoon. We actually put 2 sheets in the vein, go up to the IVC, into the heart. We puncture 2 small holes through the inner atrial septum here. This is just going to show one, but we do that under echocardiographic guidance, find where we need to go, poke the hole, and then we map this. This is the second part, so just for simplicity's sake. Then we cauterize around the pulmonary veins. So it's a continuous burning around that vein. And what it does is imagine an electrical signal coming from inside this vein that's going to travel through. This burn is going endocardial, myocardial, and epicardial ideally. And so as electricity comes in from the vein sleeve, it's going to hit that now dead tissue. So it's basically making a line of block. So it hits that tissue and stops. It doesn't put you in AFib. And so this is an electroanatomic map of what we're doing in there. This is in normal sinus rhythm. So backside of the heart here. So these are the right side pulmonary veins. Each of your 100,000 heartbeats every single day. This is the wave of electrical activity as it goes through the heart. So normal sinus rhythm goes in. Lovely. So we can follow electricity. That's kind of cool. Oh dear. This is AFib. So this is this circlet waves of craziness that are happening with AFib. You saw the last one. It was very organized. It was very nice and neat, nice wave. When you're in fib, it's a hornet's nest of electricity going everywhere. We see it, we map it every single day. This is fairly benign. This is not an aggressive case of this. This is what most people would come in with. So you can see the electricity is going everywhere, right? Then this is us remapping after we've done a pulmonary vein isolation. So this is after your AFib ablation. So we made a line of block right here, all the way around the veins. This is the backside. These are your right pulmonary veins. As we're pacing the heart, it hits that line of block and stops. So no electricity goes in, no electricity comes out. We put catheters in the veins and we try and pace out. It won't come out. Skip that. So this is why AFib is smarter than us. So this is in the operating room recently, actually. This person is in normal sinus rhythm. This is the atrium ventricle. This is in a coronary sinus, atrium ventricle, atrium ventricle. So PQRS, PQRS. The veins are quiet. The catheter is in the vein. So there's nothing happening in the vein. But I have a catheter in the esophagus. That's this orange one. Inside of the heart is in normal sinus rhythm. Outside of the heart, which is what the esophagus measures, AFib. Can't get them out of it. Can't shock them out of it. Can't do anything. So you're sitting here with these two opposed things, normal sinus rhythm inside, epicardial AFib. You can't get, it happens all the time. So people are like, why didn't my AFib ablation work? Well, I can't do anything about this. This is on the outside of the heart. Why don't you just stay in AFib? That stuff has to travel through the muscle and get into the heart at a particular time. And it just oftentimes doesn't do that. But oftentimes it does do that. So it's a cruel joke. I'll skip that for now. This is, interest of time again, a flutter ablation, right chamber in the heart. So this is after the ablation. We've made a line of block here, tricuspid valve, IVC, so you're sort of looking at it from the feet. We make a line here, electricity travels, hits this thing and stops. So we know it works, so we can test it. Then we'll kind of go through this real quick, and we got a minute or two left. You guys know Chad's VASC score? Do you need me to go through Chad's VASC score? Almost everybody can have a Chad's VASC score of 2. Almost everybody. That's important because you talk about vascular disease, that counts in your aorta, that counts on your aortic valve. Why does this count? I'll get into why it counts, but it is important to think about that. If you are a 65-year-old woman, you already have 2 points with hypertension. You have 3. It is very easy to get to a Chad's VASC score of 5. Many people in this room were just walking around with Chad's scores of 2. So we can get to the 2 is sort of a magical number to be able to anticoagulate or do left atrial appendage occlusion. Again, interest of time, Eliquis probably a little bit more effective than, no, that's not true. A little less bleeding with Eliquis than Xarelto. Specifically in women 60 and older, specifically GI tract stuff. At the end of the day, it's 6s. If someone prefers to take Xarelto because it's a once daily pill, fine, great. But Xarelto and Eliquis are probably better choices than Pradaxa. It's never a good sign when you see a CT scan with a red circle on it. This is what we want to avoid. And this is why this next topic that will give me 3 extra minutes that is important. Everyone knows we don't like Coumadin. No one likes Coumadin. It's rat poison, which is true. Everyone stops it, and it's hard to take. The same thing happens with DOACs. People just quit taking them. They're lying to you. They're lying to me. They quit taking the drug. It's fascinating. Once I figured this out, I asked them, I'm like, look, I don't care. I just want to know the answer. They quit taking them. 20 to 30% of people quit taking them. Oftentimes it's costs. Other times it's just like, I don't have a pill box. I didn't take my drugs with me. I just don't feel like taking any drugs. So know that this is a big deal. So this is also very interesting in that, oh dear, you would think that as they get sicker, they have higher risk of stroke, which is what they do. You would think we would give more blood thinners, but we don't. We have this cognitive bias. We look at it, we're like, you don't look healthy enough for a blood thinner. We're not going to give it. And that happens all the time. Whole bunch. You're like, you're too frail. You can't afford it. And we don't anticoagulate them. Those people get sick. This is an important slide. So, like I said, if you can get to a CHAD score of 5 very quickly. You can be a 65-year-old woman with hypertension, diastolic dysfunction, and maybe you had a small MI, right? And we did a cath, you don't have anything, but you have coronary disease. Your CHAD score is 5. So we know your annual stroke risk is 7%. Your annual bleed risk, higher than your stroke risk. Your annual bleed risk is 10. That's one thing. I can grab it. Your 10-year bleeding risk is 62%. So all these people we stick on Eliquis and Coumadin, whatever it might be, your bleed risk of taking that over the neck, that's major. These aren't mine. These aren't like I had a little blood when I brushed my teeth. These are major bleeds. 61%. That's huge. Okay, so why are there other options? Why are there good options? This is what we want to avoid. So this is an echocardiogram down the throat, a TEE. This is the left atrial appendage. You can see going into the left ventricle. When the heart quivers, blood pools. When blood pools, it clots. When blood clots, it clots in a left atrial appendage. When it clots in the heart, it gets pumped out of the brain. It goes north to cause a stroke. This is what we want to avoid. This is why you take Eliquis or Coumadin. It interrupts that process. So then some smart person said, hey, you know what? Why don't we plug up that hole? Yeah, let's just do something about that. So we did. So we have 2 devices now. They're 6s, to be real honest. They're both great devices. This one here is an amulet. You put, basically you put a plug in the hole, okay? This one we probably think is a little bit better long-term, avoids leaks, things like this. But again, 6s, they're both really good. It has 2 discs on it, and it covers this os pretty well. What we found with the next one, I'll show you, the Watchman, is that it doesn't have this disc. We put a little thing here, but there's a tiny little leak, and sometimes that's a little more thrombogenic than we thought. Microscopic amounts, but it's real.
I'm so sorry. This is my least favorite thing that I ever.
It's okay.
Buddy.
You're good.
Okay, so because we want our 15 minutes for fluid management, and we also want to spin for the $50. Okay, we're gonna do that later because of the tech difficulties, but you want to be back here by 8:30. And I would say maybe if you have questions, we can come.
Absolutely.
Okay, great. I'm so sorry.
Don't be at all. Thank you, guys. I appreciate your time. Oh, thanks.
You, like mag team?
Yeah.
Supplement?
Yeah.
Okay, good.
Yeah. It really doesn't. I mean, I think people need to take a ton of mag. I mean, like a fair amount,
Yeah.
like 3 times a day. And it should be the magnesium threonated sleep. And then the other ones, whether it's Magtine, Magglycinate, whatever, it kind of doesn't matter. It's whatever gives you the less runs. Yeah. You're so welcome. Thank you.
Can you show me the picture of the watch?
Yeah. So this is the amulet. So that's just TE on the inside. And so TE is back here. So this is that disc I was talking about. So we just put it in this, plug it in that hole there. I'll show you a couple more as I'm doing it. It goes away. It goes away. Every now and again, I'll see that it's actually still there, but it closes up. Because the reality is that septum is not, it's not a line. It's embryologically, it came down like this, and then it sort of fused together just because of pressure. So there's always a little bit of 25% of people have a PFO anyway. And then I'll show you these. Yes, please.